Dear ladies and gentlemen, dear colleagues, dear guests and friends, I will warmly welcome you to our autumn webinar of the EFIM Working Group Multimorbidity. First of all, I would like to thank all members of EFIM for the extraordinary organization and for the opportunity to host and chair this webinar. Especially, I would like to thank the chair of our Multimorbidity Working Group, Maximo Bernabeu, for his excellent support. And last not least, I would like to thank my friend and colleague, Professor Mine Durusu, for all our exchange, cooperation, and co-organization of the webinar and for her readiness to bring her experience, make her experience part of the webinar. Thank you very much, Mine. Now, the program, in the next step, we will introduce ourselves and then I will give a short overview about the topic, infections and multimorbidity, and then I will go on with my first lecture, and then follows the second lecture of Professor Durusu, and you all can write comments and questions to us, and at the end of the webinar, we will give answers to your questions. So I start with introduction. My name is Annette Kurle. I'm the moderator. I come from Germany. I'm living in the middle of Germany near the university town Mainz. I'm specialist for internal medicine with the focus on geriatrics and gastroenterology, and I'm Master of Medical Ethics too. I'm working as geriatric coordinator in a hospital group and as well as scientific assistant in the Institute for Ethics in the University of Mainz. And for several years, I'm member of the EFIM Working Group Multimorbidity. So now I give the word to you, Mine. It's your turn.
Thank you so much, dear Annette. First of all, thank you very much for this very kind invitation. And also want to thank Maximo for his continuing support and the wonderful work that you are doing in the Multimorbidity Working Group. So briefly, let me introduce myself. I'm a professor of internal medicine in Ankara, Turkey, affiliated with Hacettepe University Faculty of Medicine. And I have been working in the acute medical unit and the emergency care unit as a consultant for several years. And I'm the founding chair of European Federation of Internal Medicine Young Internist Working Group. And now I'm a fellow of EFIM. And currently I'm holding the position for the editor-in-chief of EFIM Academy, as you all know, which is a online platform where we interact with our members and with all the internists and other healthcare professionals through interactive modules and up-to-date knowledge. And for the last 15 years, my academic area of interest has been on vaccines and vaccine-preventable diseases, and mainly influenza. So today I will be briefly talking about influenza and just try to give my experience on the clinical perspective of influenza in elderly patients. Thank you so much. Over to you.
Thank you very much, Mine, for your introduction. Now I will go on with a short introduction to the two topics. Now, in our webinar, we will deal with two dangerous partners. On one hand, infections, and on the other hand, multimorbidity. And our focus is a risk group frequently affected by these diseases, the elderly patients. Infections are frequent diseases, the medical danger and the multifactorial side effects of infectious diseases became globally part of our life during corona pandemic. Besides infections by SARS-CoV-2, there are lots of other severe infections like AIDS, tuberculosis, or malaria, threatening the life of thousands of people all over the world. Another acute, often underestimated infection is influenza, globally widespread, seasonal, appearing, and we will hear about it in the second lecture by Professor Durusu. Either influenza, SARS-CoV, or infections in general play an important role in the context of multimorbidity. Scientific and medical progress have improved the life expectancy, resulting the demographic change is characterized by an increase in chronic diseases, leading to an increased rate of multimorbid patients. Multimorbidity is either defined as the presence of two or more chronic diseases at the same time in the same patient, or as a complex interaction of several coexisting diseases. Although we concentrate in our webinar on the risk group of elderly patients, multimorbidity is not only a topic for and a problem for elderly patients, but we have a growing group of younger patients too. Due to its complexity, multimorbidity, this phenomenon has become one of the greatest challenges of our time. Not only in medical, but in socio-economic, political, and ethic terms as well. From the medical point of view, the multimorbid characteristics, chronicity, interactiveness, and simultaneousness lead to a high vulnerability of the multimorbid patient, increasing the susceptibility and risk for diseases in general and especially for infections. The coincidence of the infectious stress and multimorbid vulnerability is dangerous and is reflected in a high rate of complications and mortality. In this process, the immune system of the people play a crucial role. And this leads us to my lecture, to the first one, immunosenescence and infections in the elderly. Before starting with my lecture, I would give a disclosure statement. There are no conflicts of interest to declare in my case. I have divided my lecture in 3 parts. First one, general aspects of infections in elderly patients. Then follow the special immunological aspects in elderly patients, the phenomenon of immunosenescence. Third part is the interaction of geriatric multimorbidity, infections, and immunosenescence. Infections are worldwide common diseases, especially in elderly patients. And in the group of people older than 65 years, we have an increase of incidence and prevalence of infections. Now, the spectrum of pathogens, if we look at this one, we find on the first row bacterial infections. Infections with all bacterial pathogens are increasing in elderly patients. Then come the viral infections, increasing especially in respiratory system since the pandemic. An important role play nosocomial infections in elderly patients. They are defined, they are associated with occasionally and temporarily hospital treatment, and even in outbreaks, elderly patients are more often affected than younger ones. These are the classical infection by Staph aureus or the Clostridioides difficile group or others. Important in the spectrum are even reactivations of latent infections. For example, reactivation of infections with zoster varicella or tuberculosis. And the opportunistic infections, which are normally found in immune-suppressed patients, are even important depending on the comorbidities in the group of the elderly. We find fungal infections by Candida species, Aspergillus, or even cytomegalovirus virus. To the manifestations, infectious diseases are most common in respiratory and urological system. An outstanding role plays pneumonia. On the third place, we find infections of skin and soft tissue. It depends on the comorbidities. Diabetes, vascular diseases are often in elderly patients, and they are associated with these group of infections. Then follow abdominal infections, gastrointestinal infections, and we have a last group with rare infections of the heart, endocarditis, central nerve system, meningitis, bone spondylodiscitis, and we have to think of infections caused by devices, as devices are more often in elderly people than in younger ones, for example, pacemakers or ICD. As the infections are often severe infections, we have a high rate of hospitalization, more inpatient than outpatient treatment. I will exemplify it on the community-acquired pneumonia. In patients older than 65 years, we have a hospitalization rate of 50%, compared with the younger ones, where we have a hospitalization rate between 12 and 13%. And this is not only an important medical aspect, but a socio-economical aspect too. Hospitalization rate, this high one, is caused by a high rate of complications. We have a wide spectrum of complications. I will focus on three groups. First of all, the infectious complications, ranging from wound disorders, abscesses, to severe sepsis and septic shock. The cardiovascular complications with arrhythmia, up to myocardial infarction rate, which is increased, and pulmonary embolism, and the neurological complications, which include forms of delirium, different forms of this, and disorders of consciousness up to encephalite and stroke. Not only we have another influence of infections, infections make not only complications, but they have a direct influence on chronic diseases. They increase the symptoms, for example, in COPD, in cardiovascular diseases, especially in neurodegenerative diseases like Parkinson or morbus Alzheimer. We find a decrease in the situation of infections and even in metabolic diseases. So the rate of complications leads to a high mortality rate. We have estimated 30% of elderly patients die from an infection, and so infections are still one of the diagnoses that most commonly cause the death of a patient. For example, in the case of a severe sepsis or a severe shock, we have a mortality rate of 50 to 60%. That is very fatal and shocking. And the trigger for these complicated infectious reactions is the special role of immune system in elderly patients. This is now the part 2 of the lecture. All parts of our body are included in an aging process, and as well is the immune system in this aging process included. We speak of immunosenescence, which is defined as the gradual decline in the performance of the immune system with increasing age. We have 2 parts of the immune system, the innate one and we have the adaptive one, and both have humoral and cellular components, and each part of the immune system is under the influence of immunosenescence, and the influence leads to a functional loss either of the different cells belonging to the innate and to the adaptive system. The functions of phagocytosis, for example, which is so important for the immediate reactions against defensing pathogens, it becomes lower, and even the B cell production of antibodies. The interaction with the cytokines is suppressed, and the cytokines do no longer stimulate anti-infective and anti-inflammatory processes. Another important factor in this immunosenescence is the role of the natural barriers. They are not really part of one of the immune systems, but there is contact with the innate immune system. Parts of the natural barriers are skin, special epithelium of respiratory, urological, and gastrointestinal system with a special microbial flora and with special protecting secrets, and under the influence of immunosenescence, the microbial flora changes and the special epithelium changes, and the effects of the natural barriers decrease. In normal case, in a healthy body, we have an immunological balance in the case of negative influences like infection or other influences. The immune system is stimulated, and following the stimulation are many immunological reactions on different levels of the immune system, with the aim to limitate, or in best case, eliminate the negative influence. How is the situation in the case of immunosenescence? We do not have the possibility of stimulation and eliminating and limiting, but immunosenescence does not lead to a balanced system of in the immune system, but we have an immunological disbalance, and in this disbalance we have the situation of a chronic inflammation status. It is characterized by reduced immunological cellular functions, an overweight of pro-inflammatory cytokines like TNF-alpha, interleukin-1 and interleukin-6, an aging of the epithelial barriers, skin, gut, respiratory system, and even an aging of the lymphatic system, a thymus involution, and the production of cells in the bone marrow is decreased. And all these factors lead to higher susceptibility for diseases. In the case of infections, we have on one hand this chronic inflammation. Inflammation is another name for it. And this makes the highest susceptibility for infections. But there is another effect that is very important, especially clinical important. We have a change in the infectious symptoms by this chronic inflammation process, by the reduced functions in the immune system. Normally, we have classical biomarkers for infections, the CRP, procalcitonin, and leukocytes. But in immunosenescent patients, CRP is often, in normal case, increased, so we can't use it as a biomarker. High temperature is often no sign in an immune senescent system. We have, instead of the classical aspects and symptoms of infections, we have other symptoms. We have neurological symptoms, delirium, influences of disorder in the consciousness. We have musculoskeletal symptoms, and the musculoskeletal symptoms are associated with bad mobility, with falls, and with a general change in the general status. The loss of classical symptoms lead to a delay in diagnosis and lead therefore to a delay in therapy. In delay in therapy in case of infections is fatal. An early therapy is important, and so we get more complications, and the high rate of complication higher the susceptibility for other diseases and for other infections. Yes. And so it is very important to think in the elderly patients when the status changes, when neurological symptoms and musculoskeletal symptoms appear. That is an important sign for infections. Now, in the last chapter, I would like to concentrate on the effects of the geriatric symptoms. We have very complex situation between infections and immunosenescence, as I've shown. And this complexity is increased by geriatric multimorbidity and the geriatric syndromes. You see an overview about the geriatric symptoms. Each of these syndromes increase the vulnerability of the patient, and each of these syndromes have an influence on the immune system, increasing the immunological functions. And for example, the wounds and ulcerations, the syndrome of this, if we think of the normal, the natural barriers, if there are wounds and ulcerations, infections in skin and soft tissue increase. And so you could find for all these geriatric syndromes effects on the immune system, hiring immunosenescence. I would like to concentrate on one of the geriatric syndromes, and this is polypharmacy. Polypharmacy is not clearly defined. It is the continuous prescription of medications, and we refer to continuous use of multiple medications by a patient. We estimate that 75% of the patients over 65 years take 5 or more medications. If we have a look to the influence between polypharmacy and immunosenescence, we have the following situation. Immunosenescence is an intrinsic factor influencing immunological reactions. Polypharmacy is an additive extrinsic factor influencing immunological reactions and making the situation worse. If we have a look to the following medications, corticosteroids, antibodies, oncological substances, proton pump inhibitors, analgesics like paracetamol or novamin sulfone, anti-infective substances, they increase the effect of the senescent immune system and the limited protective barriers, yes? And in the situation of the immunosenescence, we cannot influence much. We have no great influence, but the extrinsic factor, polypharmacy, we can take influence on this too. And therefore it is too important. Summarizing the trias, geriatric syndromes, immunosenescence, infection, we have a niveau of interaction and complexity on very many levels of immune system and the body. The geriatric syndromes increase vulnerability and increase thereby immune senescence, especially forced by the special role of polypharmacy and we have a reduced perception of infectious characteristics by the geriatric syndromes and by the vulnerability, and a change in infectious symptoms. And all these interactions lead to susceptibility, increased one of infections, and increase of complication and mortality rate. And now, what are the take-home messages? I think, first of all, you must get an awareness for this situation, an awareness for the multifactorial vulnerability of elderly patients, for the complex interactions of multimorbidity, immunosenescence, and infection, for the danger associated with infections in elderly patients, and an awareness for the possibilities of avoiding infectious diseases. So at the end with my lecture, thank you very much for your attention. Now I give to you, Mine.
Dear Annette, thank you so much. And you have really set the ground very well for my presentation. And I will just continue with where you have left, just go into deep with the effects of influenza on the elderly people and especially the people with comorbidities. So let me first of all share my screen. So yeah, thank you so much. So now I will be talking about the clinical burden and outcomes of influenza in elderly patients and what kind of tools, especially in terms of vaccination, do we have to protect our frail or fragile patients from influenza and complications. So these are my personal statements. And I will just really pick up where you have left, Annette, because as you have very, very clearly delineated, there are many, many interconnected factors that lead to interconnected outcomes. So we know that in the context of influenza, again, we see that especially older people, people with comorbidities, frail people, they really present in an atypical clinical presentation and sometimes with a delayed presentation. And of course, the chronic diseases and the multimorbidities may be just compounding the presentation. And sometimes, as I will just explain in a few minutes later, we really cannot see the underlying disease as the influenza, but rather focus on the other diseases like the aggravations of the chronic diseases and the multimorbidity. And of course, the host factors like the aging, the dysregulated immune system really can change the presentation and the clinical outcome. Frailty is another important factor. And of course, the contact with the healthcare professionals, to which level of healthcare the patient presents, whether the patient has any other risk factors like malnutrition, polypharmacy, decreased lung structure and physiology, decreased physiological reserve, decreased muscle reserve. These are all very important factors for the outcomes of influenza. Of course, due to the immunosenescence, the vaccine protection may be reduced in these people. And if these people are living in long-term care settings, the risk of exposure to an influenza can increase, and also the untoward outcomes may be at a higher frequency. So these interconnected factors can really lead to interconnected outcomes like increased susceptibility, increased morbidity and mortality due to influenza, prolonged hospital stay, and an increased transmission due to the continuing viral replication and shedding. And of course, on a system base, when we look from the healthcare economics perspective, these all may lead to and also do lead to increased healthcare costs. We know that influenza infection can cause significant functional decline in older adults. So it's not a simple viral respiratory infection. It's not common cold. We should really be aware of the fact that influenza is an important infection, and it can be as severe as to cause temporary or permanent loss of function, especially among the older adults and adults with multimorbidity and other risk factors. So here you can see that in a recent study, it has been reported that 67% of the patients who have influenza diagnosis reported to become at least temporarily housebound, and 25% remain completely bedbound. So this is actually a huge burden, not only on the person itself, but also on the caregivers and also on the community. So when we look at the comorbidities accompanying influenza, and this is a long cohort of patients diagnosed with laboratory tests in the USA, so just crossing 10 seasons, you can see that actually many of the people over 65 years of age has an accompanying disease. And here you can see that like 75% of them has a cardiovascular disease, majority of them hypertension, more than 50% of them has a chronic metabolic disease, and like 30% of them has obesity. And you can see that there are a vast array of diseases that may be present in these people. So having a chronic disease do increase the susceptibility to influenza infection, but in the meanwhile, it also increases the risk of untoward outcomes and maybe functional decline and temporary or permanent loss of function in these patient populations. So let us go again through the hospitalization journey of these patients. So when you look at the influenza admissions, and this was a study done over 4 seasons in the UK, you could see that actually these influenza admissions had a very high cost, like over 400 million pounds over the 4 seasons. And the average admission costs were heavily impacted by age and the comorbid status. And the comorbid patients were representing 95% of the cost. So the patients with the comorbidities, they do not just have the personal burden of influenza, but they also put a high pressure on the healthcare system and result in a high economical burden on the influenza side in the healthcare system. So when you look at the length of stay of these patients in the hospital, you can see that if these patients have comorbidities, the average length of stay in the hospital increases, and this length of stay also increases with regards to the increasing age. So older people having comorbidities are at the highest risk of spending more days in the hospital due to influenza. And of course, we're not just talking about the short-term impacts of influenza, like the acute disease, hospitalization, even intensive care unit admission and death, but we are also interested in the longer-term impacts, because what we do actually see among people who are older or who have comorbidity is that they may have persistent functional decline, they may need assistance in activities of daily living, their quality of life may be impacted, and they may even require nursing home admission after an influenza episode. And of course, when you look at the community-wide impacts, these all translate to an increased antimicrobial resistance because of the secondary bacterial infections or inappropriate antibiotic use, lead to utilization of healthcare services, and of course the caregiver giver burnout, and also the financial impacts at the micro and the macro level when we talk about the cost of influenza on these people. When we look at the laboratory confirmed inpatient influenza cases, I mean, these were the cases who were admitted to the hospitals from 22 countries from the Global Influenza Hospital Surveillance Network cohort. And when you look at more than 15,000 laboratory confirmed cases, we have seen that 5% of these cases required intensive care, more than 3% of these cases required mechanical ventilation, and nearly 3% of these patients could not be discharged from the hospital because they died in the hospital. And when you just project these percentages to the total number of people getting infected with influenza each year, these numbers are really huge. And in the low middle income countries, you can see that the intensive care admissions can reach to sevenfold more when compared to other countries. So the disadvantaged populations and people living in poorer countries also do have a higher burden of influenza and influenza-related complications. And when we compare the elderly ones with the younger ones, as also been just pronounced in the previous lecture, the elderly ones has a higher instance of hospitalization. So if a younger one, if an elderly one is infected with influenza, when compared to a younger person, there is a 4 to 6 times risk of hospitalization for that elder person. And when you look at the all influenza-related hospitalization days, over a third of all these hospitalization days belong to people who are more than 65 years of age. So increasing age is a risk factor for the complications and untoward clinical outcomes of influenza. So what about the probability of death? So this is again a very recent study from Japan, and they have looked at the progress of the disease within 30 days, within 60 days, and within 90 days. So when you look at this bar on the left-hand side, you can see that more than 60,000 people were, the data of more than 60,000 people were analyzed. And when you look at the numbers, in the first 30 days of influenza diagnosis, 1% four of the patients die. And within 90 days, within 3 months, this reaches up to 2.5%. But when you look at the patients over 75 years of age and older, the 90-day mortality rate increases to 4%. So for every 100 patient dies in 3 months due to influenza. And again, when you look at the incidence of influenza during a season, this is really a huge number in a country, in a community. So the mortality burden gets higher and higher with the increasing age, that's for sure. So what about the factors related to frailty? When we compare the pre-frail people with the frail people, we can see that the risk of contracting influenza increases with this stage of frailty, but also the hospitalization rate due to influenza increases. So pre-frail people are also at increased risk of hospitalization due to influenza, but if they are frail, the risk increases 3 times when compared to non-frail people at the same age group. So not only older age, but also frailty status is an important risk factor for the hospitalization due to influenza. And of course, when we're talking about the burden of influenza, it's not just the disease burden, it's not just the acute infection or the mortality. So actually, it has been like maybe 5 or 10 years that we have noticed that influenza causes acute cardiovascular events and cerebrovascular events. And this is a slide I'm just showing in each and every of my talks because I think that's very, very demonstrative. Here you can see that again, a cohort from Denmark, within the laboratory confirmed influenza cases, the risk of acute myocardial infarction increases more than 17 times in the first 3 days of a laboratory diagnosis of influenza. And the risk of stroke increases 10 times. And this increased risk continues in the first 30 days. And here you can see that sometimes patients admitted to the hospital with acute myocardial infarction, with stroke, can really be triggered by an influenza infection, which may never be diagnosed. So there are many excellent cohort studies from coronary care units that show that actually just an important percentage of people who are admitted to the coronary care units with the diagnosis of acute myocardial infarction actually have positive influenza PCR test results upon their admission. So sometimes this these acute complications like stroke or myocardial infarctions can really mask the infection triggering these events, as also been just pronounced by the previous speaker. So the clinical presentation may completely be different in the elderly people and people with comorbidities. And also, another interesting and exciting area has emerged in the recent years, and some of the viral infections have been shown to be related with some of the neurodegenerative diseases that we are really afraid of in the community. And when you look at this study published in Neuron very recently, you can see that influenza and pneumonia diagnoses were significantly associated with Alzheimer's disease, with amyotrophic lateral sclerosis, dementia, Parkinson's disease, and vascular dementia. And this was a study done with the data from the Finnish Biobank, and it was validated with the data from the United Kingdom Biobank. The only neurodegenerative disease within this cohort that could not be linked to influenza was multiple sclerosis, and multiple sclerosis was shown to be associated with Epstein-Barr virus infection. So it's very clear that viral infections can trigger neurodegenerative diseases, inflammatory diseases, that we can never maybe guess that these diseases may be due to these viral infections. So it's very clear that we need to protect the frail community, the elderly people, people with comorbidities from influenza infection and its complications. So the influenza vaccination is the most important tool that we have in that sense, but we also know that the influenza vaccination cannot 100% protect the patient from the infection itself, but it can protect the patient from being admitted to the hospital, from being admitted to the intensive care unit, from mortality, and from all these long-term consequences of influenza. So when you look at the WHO recommendations, individuals with comorbidities and risk factors and older individuals, including those living in the long-term care facilities, regardless of their age, are within the target groups for influenza vaccination each and every season. So we really need to administer a dose of influenza vaccine to these people every season, every influenza season. But protecting older people, of course, cannot maybe dependent on preventing the infection 100%. But we know that the influenza vaccination reduces the risk of death, pneumonia, and frailty among these people. Because when you prevent a frail patient or an elderly person being admitted to the hospital, you can really prevent the other consequences of hospitalization, like loss of muscle function, sarcopenia, and decreased quality of life. And when you look at the relative decrease in all-cause mortality, different studies have shown different results, but you can really decrease the mortality rate, the complication rate due to influenza at a very high percent, a relative high percent among these people. And of course, if influenza is related to cardiovascular diseases, then it's very clear that we can prevent these diseases with vaccinating the people with cardiovascular diseases with influenza vaccination. And this is a graphic showing the results of a meta-analysis of 6 randomized controlled trials, including nearly 10,000 patients with underlying heart diseases. And here you can see that by vaccinating these people with the influenza vaccine, you can decrease the primary outcome. And here you can see the composite points, the outcomes of these primary outcome by 26%, cardiovascular death by 37%, and all-cause death by 28%. And I think it's fascinating that these numbers are in comparison with the interventional procedures like angioplasty, maybe the use of statins, acetylsalicylic acid. So it's very clear that influenza vaccination is now a primary and secondary protective or preventive tool for people with underlying heart diseases. And when we vaccinate diabetic patients, again, we can have some risk decrements, like we can decrease the risk of cardiovascular death, we can decrease the risk of death from heart attack or stroke, and also we can decrease the risk of hospitalization due to acute diabetic complications. And I think it's very important to protect people with chronic diseases from being admitted to the hospital for any reason. So how can we protect people with vaccination? And as I have said before, the risk of being admitted to an intensive care is decreased by 26 to 59% in different studies, and the risk of death was reduced by 31%. So we need to know that although we cannot prevent the influenza infection 100%, we can really prevent the severe consequences of influenza infection by vaccinating our patients and communities. And also we can protect the people from stroke. So this is again a recent and very interesting study. So it says that when we vaccinate people with influenza vaccination, we can decrease the incidence of stroke like 22.5% in the following 6 months. So it's a very interesting and exciting area of research, how we can decrease the risk of neurological and neurodegenerative diseases by vaccinating people with influenza vaccination. And of course, there are many factors that affect the effectiveness of influenza vaccine, and immunosenescence is an important factor. It not only increases the risk of infection, it also decreases the immune response of people, the elderly people, to the influenza vaccination. And here you can see that frailty, comorbidities, the accompanying immunosuppression may also decrease the response that a person gives to the vaccines. So we have some innovative vaccines at the moment to provide a better protection to elderly people, to people with comorbidities. And then flu-1 is a pragmatic, active controlled randomized trial where they have tested to administer a standard quadrivalent influenza vaccine or a quadrivalent high-dose vaccine to elderly people. And what they have seen that the relative vaccine effectiveness of the high-dose vaccine for preventing hospitalization was 64%, and for preventing all-cause death was 49%, when compared to the standard vaccine. So we now have different and new tools, innovative vaccines that we can have, that we can provide better protection to our frail and elderly people. And I just would like to give two examples from these recommendations. The STIKO of the Germany recommends adults more than 60 years of age with a yearly vaccination of an inactivated quadrivalent high-dose vaccine. And also the American Immunization Practices Council recommends that elderly people over 65 years of age preferentially receive an innovative vaccine like a high-dose vaccine, a recombinant vaccine, or an adjuvanted vaccine in case they're available in the countries. But of course, if these vaccines are not available, we will go on with vaccinating our people with the standard inactivated influenza vaccine each and every year. And we also know that this also has a return on investment. So it has been shown that every $1 spent for influenza vaccination has a return of investment of between $5 to $22 for the healthcare system. So please do vaccinate your patients, your communities, because it's not just to prevent the influenza infection, but also to prevent hospitalization, complications, maintain a quality of life, independent mobility, and to protect our healthcare systems from the pressure of the seasonal influenza when we have a seasonal influenza peak, especially to protect the more fragile and frail patients in our communities. Thank you so much.
Yes, Diamine, thank you very much for this excellent presentation about influenza and the vaccination and all important facts of multimorbidity in context with this underestimated acute infection. Yes. Now, let's have a look. There are still no questions in the chat. Perhaps we wait for 1 or 2 minutes. It's a possibility to give the questions, but I think both lectures have shown the complexity of this topic, infections and multimorbidity, and we must be aware that this is a topic that will become more important in the next years by the increasing dates. So now we have a first question. Mine, it is to you. When is the best time to vaccinate?
Yeah, actually, it's a great question because, of course, we are mostly now talking about the Northern Hemisphere as we represent the European region. So, in the Northern Hemisphere, the seasonal influenza activity usually starts in October, November, but it peaks in December, and it has its first peak by the end of December and start of January, usually with influenza A. But in March, we also do see a second peak with influenza B, and influenza B infections can really be very severe, especially in the fragile population. So I think the best way to protect our communities is to start to vaccinate at the end of September or at the beginning of October. But this does not mean that we have lost our chances to vaccinate. So if you see a patient, especially a high-risk patient in February, in March, go on and vaccinate that patient as well, because the influenza activity goes on until the end of April. Last year in Turkey, we have seen cases in June. So if you have a vulnerable population, an elderly population, you can really appreciate that this is very important to protect these people. So we have a window of opportunity to vaccinate people starting from autumn to the end of spring the next year. And of course, we should use the seasonal influenza vaccine each year because the WHO renews the vaccine composition each year due to the circulating strains. So we have a large window of opportunity, and it will be good, of course, to provide protection as soon as possible, but we can go on to vaccinate our communities until the end of April, maybe. So it's important to keep that in mind.
Thank you. There is another question for you. Are those that do not contract influenza by coincidence or herd immunity also more protected from influenza?
Actually, it's very hard to talk about herd immunity with regards to influenza because in order to talk about herd immunity, you need to reach about like an 80% vaccination coverage rate in the community or 80% infection rate. The important thing is that if you get infected with influenza A, H3 and 2, for example, that does not mean that you are protected from the other strains. So talking about herd immunity is not very easy in terms of influenza. You can be infected with more than one strain every season, and you really need to reach a very, very high level of vaccine coverage rates, more than 75%, in order to have some kind of herd protection in the communities.
Yes, and then again we have another one vaccine, a second in March?
Yeah, we cannot actually recommend it from a scientific perspective in the Northern Hemisphere because we all know that the duration of immunity provided by influenza vaccines do not last too long, not more than 6 months maybe. So some experts sometimes advise on that, but scientifically we cannot speak about two doses of vaccination in the Northern Hemisphere. But what we may really do is to, if we can access, of course, the high dose vaccines or the adjuvanted vaccines, to use those vaccines for a higher and better protection. But in the Northern Hemisphere, we still recommend just one dose of vaccination each year. But in the tropic zones, the influenza season goes on like throughout the whole year. So in those tropical regions, sometimes experts recommend two doses with different vaccine compositions sometimes throughout the year. But for the Northern Hemisphere, just one dose of vaccination is adequate for the time being.
And I think we have a very important and interesting question. What about vaccination in case of respiratory syncytial virus RSV? And what do you think of the triple antiviral vaccine, flu, COVID, RSV? Huh.
Yeah, this is
What do you think?
Yeah, it's also a great question. So we also do know that RSV infections have a very high clinical burden, and the surveillance data show that elderly people, people with comorbidities, and immunosuppressed people are at increased risk of respiratory syncytial virus infections and their complications. So now many countries recommend RSV vaccination to those people over 75 years of age and to people with risk factors between 60 and 75 years of age. So it's of course provides an additional protection in terms of respiratory infections. What about the triple vaccine? So I think it depends on the region that we live in. If you are in a country which has a low vaccine hesitancy, especially for the COVID-19 vaccines, of course it's an advantage to administer all three vaccines at the same time, because it has been shown that co-administration does not decrease the immune response, but of course it increases the accessibility of the vaccines. But in regions where especially COVID-19 vaccine hesitancy is higher, I'm afraid that we can also lose some people in terms of influenza vaccination if we just insist that we will administer these vaccines altogether. So it will depend on the vaccination trust and hesitancy balance of the communities that you are working in.
Okay. And we have one question concerning Tamiflu.
Oh, yeah, it's oseltamivir is an antiviral drug, of course, that we can use in influenza cases, and we recommend to use oseltamivir for patients who present in the first 48 to 72 hours of infection in order to decrease the complications and decrease the hospitalization stay, but not to all people, to people with, again, comorbidities and risk factors, elderly people, and to people who have already been admitted to the hospital due to influenza. But we do not recommend it to a otherwise healthy person who present with influenza from an outpatient setting. So we should be selective for the high-risk people again.
Mhm.
And I also need to just emphasize that, of course, we say that the high-risk patients are at the target group for influenza vaccination, but influenza vaccination can be used for everyone over 6 months of age. So if you have available and accessible influenza vaccines in your own country, you, of course, are more than welcome to suggest and administer influenza vaccine in otherwise healthy people as well. It's all about the accessibility and the availability of the vaccines. I also need to emphasize that.
Yes. And there is one question that's interesting too about the simultaneous vaccination, influenza and other vaccine, and the question, how long should we wait between? No? Okay.
No need to wait because influenza vaccines are inactivated vaccines. So I have not talked about the live attenuated vaccines that we are using sometimes in children, but in the elderly people, in adults, we use the inactivated vaccines, and you can administer inactivated vaccines simultaneously or within any period of break that you want. So there's no need to wait. You can administer simultaneously all the inactivated vaccines like influenza, RSV, pneumococcal vaccine, tetanus, diphtheria, and acellular pertussis, and even the new recombinant herpes zoster vaccine. All can be administered at the same time or in any interval that you like.
Okay, thank you very much. So I think we have answered all questions, and I think we have given a lot of information. Thank you very much for all the attention of the participants. Thank you again, Mine, for your excellent lecture, and thank you for answering all the questions. I wish you a nice afternoon, and I hope you have got important information for your clinical and daily work. Now I will close the webinar. Yes. Bye.
Much. Bye bye.
Bye bye.